backbone like this.
What is backbone like this? What does that mean? What is the term for backbone like this?
Called kyphosis.
Kyphosis. Okay. So osteopenia is the severe osteoporosis, like very like the severe like bone mass loss. Okay. Okay, so kind of like a loss in bone mass is a normal age-related change. It's kind of like a normal age-related change. Okay, but excessive bone loss is not. Okay, so that's why like we look at those root cause, like maybe the medication, a disease process, lifestyle, like why my patient is losing bone mass. Okay, but again, like as age, we lose some. Okay, and then again, it can cause kyphosis. What is kyphosis? Curvature, like the abnormal curvature of the spinal. And what is the biggest problem when it comes to kyphosis? We will talk about it. Breathing, okay, pain, because like your patient like he can't stand tall, gait. How look at their like now their body image, their social. Okay. And so health promotion and maintenance. Okay, we want to educate our patients to avoid any risky lifestyle behaviors. Okay, so again, as I said, males, especially like younger adult males, they're at risk for like these like risky behavior type of injuries. Okay, so like accidents is one, then illness is the second. Females, okay, vitamin D deficiency, calcium, and also think about estrogen, like those postmenopausal, like menopausal females. What's happening to their estrogen? Decreasing. So decreased estrogen equals we are losing bone mass. So we put them on what? Estrogen replacement therapy. Weight bearing activities. Okay, so we want to increase and promote weight bearing activities and then also muscle strengthening activities. Tobacco. This is something I learned from your textbook, guys. Like I was not aware of this, but then tobacco it can decrease your bone density. Yep. And then also can cause like muscle atrophy. Alcohol use. So with alcohol use, what happens? We are losing those vitamins and minerals as well. So when you're losing vitamins and minerals, we are losing what? Bone density. So which mineral is responsible for be related with the bone? Calcium. Okay, which vitamin? D. Okay. So your history. Ask your patient about any traumatic injuries. If they have it in a motor vehicle accident, ski accidents, those like motorbikes, dirt bikes. Pain management plan. Okay. If your patient has any of those injuries or have any musculoskeletal disorders, so assume pain. Your patient is in pain, and then we want to make sure they have a pain management plan, pharmacological and non-pharmacological. Any previous or ongoing illnesses, okay? Lifestyle, okay? So with the lifestyle, anything that occupation and lifestyle, where you have those repetitive like joint movement, that could be the culprit. Like any allergies, drugs, and any supplement use. Nutrition history. So you're looking for protein, calcium, and vitamin D intake, okay? And then we're looking for family history and genetic risk. So any skeletal system disorder or musculoskeletal disorder that is genetic. Huh? Yeah, gout. Is it genetic?
Yeah.
It is.
I think it is actually. This is very about this, right?
Okay. So again, like, that's why we do the health history, subjective data, like, like family history, genetic history, because we are looking at those, like, predisposing factors, like, what is my patient at risk for, what I want to prevent and what I want to treat. Okay. Onset of any current problem. So again, you're going to do your PQRST, okay? When did it start? How severe it is? What makes it better? What makes it worse? And anything that they're doing to cope with it. So they're presenting their health conditions, date and time of onset, factor, so again, you're all repeating my PQRST here, okay? So pain can be related to bone, muscle, or like joint problems. So with musculoskeletal problems, like we are looking at pain, okay? That's the one thing we are looking for, like we want to treat. Because what happens if your patient is in pain because of the joint pain or the muscle pain? Huh?
Refusal of participation.
Refusal in participation, what else? It will take toll on their social health, okay? Occupational health, relationships, okay? Again, like, talking about like, muscular disorders, there's a medication, gabapentin. How many of you are familiar with gabapentin? Okay, so we give it for like what? For neuropathy, any type of like, like muscular disorders, like, again, like we have nerves there. So if when you're giving your patient gabapentin, what are you educating your patient on? Like, for gabapentin? Drowsiness. Why drowsiness? Why this is the big one? Suppressant. Because it's a safety risk. You're looking for the safety. So like you want to teach your patient, like, do not take this medication first thing in the morning, or, do not drive, fly an airplane, take a nursing exam. Don't take it with alcohol, like, because it's going to suppress your nervous system further. Just something I thought about. It's relevant, but like not to this slide. Range of motion exercises. Like, we are familiar with like active and passive range of motion? Mm-hmm. Okay. We need to repeat the extension, flexion, hyperextension. I'm not going to test you guys on that, but then again, you need to know the terminology and what it means, because this is what you will get exposed to, maybe like exam after this, the next semester, or the NCLEX exam, and also in the real nursing world. I know the proper terminology. What is flexion, what is extension, abduction, adduction, pronation, supination, every one of that. You're going to do the assessment, posture and gait, okay? So it will like, your body's build, alignment, when your patient is standing or walking. Mobility and functional assessment, okay? So let's say with the mobility and functional assessment, we want to look at like, their range of motion. So mobility always, it doesn't mean like ambulation, okay? It means like range of motion, okay? And the functional assessment. Let's say you're taking care of a patient, like after like a motor vehicle accident, okay? And we are we're suspecting a fracture to their like left lower extremity. Okay. So are you going to assess for the mobility or the ambulation care? So what do we assess first, like in those trauma situations? We assess for mobility first. We want to make sure, like, the patient can move the extremity. There is range of motion, okay? Ambulation is not a priority in that case, okay? What if your patient has fractured a tibia or a femur, okay? You're going to cause more issues. But always assess for mobility. Okay? Ambulation if possible. Neurovascular assessment, so assess for those, assess peripheral vascular and the nervous system. Related changing, starting with the injury site. So when we are assessing for the neurovascular change due to any trauma or injury, we start at the site and then move proximal or distal to the site, okay? But it always starts at the site where the culprit is. Psychosocial assessment. Anxiety, depression, okay? Think about your patient's status post amputation, okay? How it changed their social image, their body image. Now this is the meat of this chapter, assessments, because diagnostics, okay? So with this diagnostic, we are going to carry this slide over to the next two chapters or three chapters, okay? And after this chapter, I'm going to stop talking, because we will jump into the disease process and we will do the same thing we did last time. I will assign you a topic and the notes, like exactly what I want you to write in your notes, okay? Now we know the drill. Those notes are very important, okay? If there is any information that I need to supplement with, that maybe you're missing, I will talk and fill in the gaps. So let's talk about the diagnostics here. Lab. In your book, there's a chart, there's a table. So for the labs, we are looking at ALP. This is your alkaline phosphate. Okay, this enzyme is normally present in blood. It is increased with bone or liver cancer, or if there is any injury to the bone or liver. Okay, but however, it is slightly elevated in older adults, like slightly, not severely. Okay, then we have our CK MM. This is your creatine kinase. So know the normal ranges. So for ALP, it is 30 to 120. CK MM, your creatine kinase. For men, it is 55 to 170. Women, it's 30 to 135. Okay, so this creatine kinase, the CK, is elevated due to any muscle trauma, any muscular dystrophy, or weakness. And then we have our LDH. This is your lactate dehydrogenase. The normal range is from 100 to 190. Again, it is slightly elevated in older adults, like the slight elevation is a normal age-related sign. The elevation of this for LDH indicates skeletal muscle necrosis, cancer, and muscular dystrophy. Then we have our AST. This is your aspartate aminotransferase. Normal range is from 0 to 35. Again, slightly elevated with age. Okay?
First one is ALT, right?
ALP. P. This one is AST. Okay.
What's the value for ALT?
30 to
0 to 35.
Well, for AST, 0 to 35. Thank you, Leah. So increased AST levels indicate muscular, skeletal muscle trauma. So when we are reading about these labs, just know the normals and what it indicates when the levels are elevated, okay? Or in some cases, when they are depleted. Do not go deep down into the microbiology on the cellular level, just like the basics. What this lab means and what it indicates when the levels are up or down, okay? Because your book can go into details. So next one is your ALD. This is your aldolase. Your normal range is 3.0 to 8.2. And the elevation in ALD, like D as David, is related to polymyosis. So what is polymyosis? So it is kind of like increased muscle inflammation, and it is due to chronic RA, rheumatoid arthritis. And also, through, it's elevated when your patient have dermatomyositis. What is dermatomyositis? Purplish skin rash. Okay, now we're going to move into your calcium, serum calcium. Pardon me? Yeah. Yes. Serum calcium, your normals are 9.0 to 10.5. So now this one is decreased with age. So your calcium goes down with age, but slightly down. Why is that? Yep, decreasing bone mass, or like the bone mass is happening due to the loss of calcium. Okay, so who remembers like hypercalcemia and hypocalcemia? So if it goes up, if it goes down, this is your hypocalcemia. It indicates osteoporosis and osteomalacia. And hypercalcemia, high calcium levels, you will find them in when there is a metastatic bone cancer, bone fracture, and Paget disease. What disease? P-A-G-E-T, Paget. Next one is your serum phosphorus or phosphate. Your normal is 3.0 to 4.5. Again, this one decreases with age. It slightly goes down with age. So excess of phosphorus or phosphate, hyperphosphatemia, will be present if there is an indication for bone tumor or bone fracture that is in healing stage. Low levels, which is your hypophosphatemia, will be present when there is osteomalacia. And these are your labs. For the normal values or like for the lab values, please bring your index card. And just like know what is the normal age-related elevation or like normal age-related depletion, if any of those. And what it means when they go up or down. Then we have our radiography. What is radiography? That's just your x-rays. Okay, we are measuring the bone density, swelling, alignment. So the patient teaching is to what? Remain still. We are trying to take a picture. Just don't say cheese. Stay still. Then we have our nuclear scans. This is a radioactive mineral. In this one, like radioactive mineral is injected to view the skeletal muscle, to view the entire skeletal system. And we do this study to detect tumors, arthritis, bone infection. We will talk about bone infection, which is osteomyelitis. Pain that, like if somebody's complaining of bone pain, but we don't know the cause, we don't know the etiology, so we will do the nuclear scan. So the injection, this radioactive isotope injection is given 4 to 6 hours prior to the scan, because we want the skeletal muscles to absorb this isotope. Okay? The procedure itself will take about 30 to 60 minutes. If your patient is confused, because we want our patients to remain very, very still and stable, if your patient is agitated or confused, then we can use mild sedation. We're not going to intubate them or put them under anesthesia, just like maybe mild sedation, maybe a worse set. Will do the trick. So there are like no special care after procedure. So with this, the radio, like with the contrast, it metabolizes through your kidneys. With these isotopes, there's like no real renal impairment that is going to happen, because these isotopes, they get absorbed through your GI system and get flushed in the stool. So make sure your patient is not constipated. Okay. And the next one is your MRI. We already know MRI from the neurological standpoint. So again, for MRIs, we want to make sure your patient, if they're claustrophobic, then we can request for open MRI, but that is like not very definitive. So for agitation, you can treat it with some benzodiazepine, anti-anxiety meds. If they're sensitive to noise, offer them earplugs. But then again, it is to assess for any tumors, any deformities, and to kind of look at your skeletal system. Then we have our ultrasonography. We do it for the soft tissue and to assess for the bone infections. Next one is your biopsies, bone biopsies. This is an invasive test, and it is painful. And we do this to confirm infection or cancer growth in the bone. So the bone cancer is one of the most painful cancers out there, and the blood cancer, of course. So we have 2 types of biopsies: needle biopsy, where we will advance a needle and core the bone and pull the samples. And then we have our open biopsies, where we will make incisions, open the bone, and take the sample out. So for both of them, open or closed, there's a tissue integrity. We compromise the tissue integrity. So we are concerned about what? Pain, inflammation, infection, okay? So we're going to address all of that. Then we have our arthroscopy. It is like, it's an invasive procedure. Again, if you are working in these areas and you're sending your patient for any of those procedures, you should be ready to tell them what they are, because your patient will be asking you for these procedures. This is an invasive procedure. What we do, we have like a fiber optic tube inserted into joint to assess the ligament, meniscus, and joint surface. So this is not the fiber optic catheter. We are like advancing through somebody's esophagus. We are going straight to their skeletal system. So the most common areas are knees and shoulders. This could be done, this is like done outpatient in the same day. So before we do this procedure, pre-procedure, we want to check patient's mobility and signs of infection. If your patient is infected, has some sort of infection going on, we will not proceed with this procedure. So just gonna make a note anywhere, just not for this scope or this procedure, for any of the invasive procedures, surgeries, we always check patient, like infection. We always make sure your patient does not have infection going on, okay? If your patient has infection, we will not go through with any of those invasive procedures. It's cardiac, renal, neurological, doesn't matter. If it's invasive and your patient has infection, we do not proceed with these diagnostics until this infection is cleared.
About medication.
So we are not using any of the contrast right here. So like
For bleeding,
for bleeding, yeah, if they're like on blood thinners, yes. If they're on blood thinners. But like, so the post procedure, we are monitoring their pain, we are controlling their pain, infection, and inflammation. So this is where the arthroscopy is. Any questions on this chapter so far? Okay, let's do these few questions. The nurse is caring for 4 female clients. Which client does the nurse identify at highest risk for low bone density? B? B. B. 6-year-old. Which client statement does the nurse identify that reflects understanding of health interventions to prevent musculoskeletal problems? Right. Okay. Test is this easy. I think that we overthink and we just gonna get scared and intimidated. Just prior to handing arthroscopy for surgical repair, what question will the nurse ask the client? Select all that applies. Okay. D, because we want to check their mobility. Okay. So, like this one is complete your exercise, like I don't care, like if you worked out with your party or not today, but then yes, do you understand the post-care information? Because it's an outpatient procedure and your patient will be going home. And we want them to be mindful of like, pain control, infection, inflammation, bleeding and all that. And then the E, definitely E, because it's an invasive procedure. So what? Consent. Okay, guys.